Greetings students, I'm Dr. Bonama Devi, Professor Pathology. In this session, we are going to deal with pathogenesis of viral hepatitis, morphology, complications and consequences of viral hepatitis. To begin with, pathogenesis. Hepatitis A virus is usually transmitted by fecal-oral route. It replicates in the liver and the virus enters into the circulation, the viremia occurs and the virus is excreted through the feces in about 10 to 12 days after the infection. The virus excretion may continue for up to 3 weeks after the onset of symptoms. Usually, hepatitis A virus can cause acute viral hepatitis, and this is usually a self-limiting disease. Hepatitis B virus is the only DNA virus. It is transmitted by parenteral or mucosal exposure. It gains entry into the hepatocyte. It replicates within the hepatocytes by releasing its core particles, by integrating its nucleic acid with the host DNA, and it has a unique reverse transcription replication, and it translates, and there is assembly of the core particles, and it buds into the endoplasmic reticulum, and then it is transported to the cell membrane as vesicles, and then it is released. Hepatitis C virus is an RNA virus. It is also transmitted through the parenteral route. The organism gains entry into the hepatocytes through the process of endocytosis. It releases the RNA nucleic acid material, and with the help of ribosome, it translates into polyprotein, and with the help of protease, it is cleaved into viral proteins. The RNA polymerase is an enzyme which helps in the RNA replication. So the drugs would be targeted against these steps in order to prevent the viral replication. And once the viral particles are assembled, it is released out of the cell. The hepatitis C virus can cause chronic liver disease because of its functional proteins, that is 2 envelope proteins and 5 core proteins, and also it is capable of evading the immune system with the help of these structural functional proteins. It has a high mutation rate. It has 7 genotypes and numerous subtypes, and this organism is capable of producing a dynamic population of closely related but not identical ones, viral genomes that exist within a single host or population, which is called as quasi-species. And it is capable of evading the antibody attack, that is the E2 targeting antibodies would be neutralized by the altering its epitopes, and it shows an impaired antiviral response because of the cleaved proteins, viral proteins which are synthesized. The other organisms would be including the hepatitis D virus, which is also known as Delta virus. It is capable of causing the infection only in the presence of hepatitis B virus. Hence, it is called as superinfection. And hepatitis E virus, this is transmitted by fecal-oral route, and it can cause acute viral hepatitis, which can lead to fatality because of massive necrosis, and it is more common among pregnant women. So the consequences of hepatitis infection would be ranging from acute asymptomatic infection without any complications, or it can be acute symptomatic infection with recovery, and it has different phases like incubation period, symptomatic pre-icteric phase, symptomatic icteric phase where there will be clinical manifestation of jaundice, and convalescence phase. Or it can present as acute liver failure as it could occur with the hepatitis A virus and E virus in 10% of cases, or it could progress to chronic hepatitis, which would be symptomatic, and there will be biochemical and serological evidence of the continuing or relapsing hepatitis disease for more than 6 months. Or there could be a carrier state. A carrier is an individual who harbors and can transmit the organism, but the person will not manifest any symptoms. So for hepatotrophic viruses, carrier state would be described in two different scenarios. That is, an individual who harbors the virus but have no liver disease, or an individual who harbors the virus and have asymptomatic non-progressive liver damage. So the acute infection with any viral hepatitis organism, 65% of the cases would be subclinical and it would recover 100%, or 25% can be present to the progressing to the acute hepatitis, of which 99% would recover, but 1% would progress to fulminant hepatitis, which can be ultimately leading to death, or it will require liver transplantation for the patient to survive. Or acute infection, 5 to 10% can progress to chronic hepatitis, and most of which would be recovering. 20 to 30% can progress to cirrhosis of liver, which is more common with the hepatitis C virus, and which would be ultimately leading to death, and the patient will not survive without the transplantation. And 2 to 3% of the cases of chronic hepatitis can progress to hepatocellular carcinoma. So the hepatocellular carcinoma associated with the hepatitis B virus or C virus, or it could be associated with alcoholism or aflatoxin B1. It causes an injury to the liver. So there will be necrosis, and to compensate that there will be proliferation with the help of stellate cell activation, and as a result of which there is abnormal liver nodules are formed with the excessive collagen deposition, which is called as cirrhosis. And initially it would be a hyperplastic nodule, and with the superadded genomic instability it can progress to dysplastic nodule, and with marked genomic instability and loss of P53 it can progress to hepatocellular carcinoma, and this can be either well differentiated, moderately differentiated, or poorly differentiated. So during this conversion from hyperplastic nodule to hepatocellular carcinoma, there would be associated telomerase reactivation for the cells to proliferate uncontrollably. So moving on to the morphology of hepatitis. In acute viral hepatitis, macroscopically, the liver may be normal in size or enlarged due to inflammation, or shrunken in those cases that are associated with acute liver failure and massive liver necrosis. Microscopically, the liver would show portal and lobular inflammatory infiltrates predominantly of lymphocytes, mononuclear cells. And the hepatocyte injury can lead to necrosis or apoptosis of the cells, which is called as councilman bodies. And the necrosis can be confluent, or it could be progressing to panlobular or panacinar necrosis, or bridging necrosis, which is nothing but the necrosis is connecting two vascular structures. And if it is massive hepatic necrosis, it could be resulting in liver failure. In chronic viral hepatitis, the histological features would be dense portal lymphocytic or lymphoplasmocytic inflammation with fibrosis, and it often crosses the limiting plate and lead to the injury of the periportal hepatocytes, which is called as interface activity. And there will be fibrosis with increasing liver damage. Initially, it will be presenting as portal and periportal fibrosis around the portal tract, and later it will be developing between the two portal tract region, which is called as portoportal bridging fibrosis, and when it is pronounced throughout the liver, it is called as cirrhosis. Particular subtypes of chronic viral hepatitis would have a distinctive features. Like in chronic hepatitis B infection, there would be swollen endoplasmic reticulum of hepatocytes, which is due to the filling up of cells with the endoplasmic reticulum with the hepatitis surface antigen, which will give to a appearance called as ground glass appearance. And this can be demonstrated with the immunostain for hepatitis B surface antigen and core antigen. In chronic hepatitis C infection, there will be dense lymphoid aggregates which can be so dense to form a lymphoid follicle in the portal tract, and there can be associated steatosis and bile duct injury. So in chronic viral hepatitis, due to hepatitis C virus infection, we are able to appreciate the dense mononuclear cell infiltrates, that is blue dots we can see, which is expanding the portal tract, which is nothing but the lymphoid aggregate, and it can form a delicate bridging fibrosis, and later it can progress to the cirrhosis. To summarize, hepatitis A virus is transmitted through fecal-oral route. It can cause acute hepatitis and does not lead to chronic liver disease. Hepatitis B virus is transmitted parenterally, with most infections being subclinical, but it can cause acute hepatitis, chronic hepatitis, and cirrhosis. Hepatitis C infection is often associated with progression to chronic liver disease in 80% of cases, while acute infections are almost always subclinical. Hepatitis D virus is a defective virus. It requires hepatitis B co-infection for replication and infection. The hepatitis E virus can cause acute viral disease, but it could be severe in pregnancy, and few cases could lead to the chronic hepatitis in immunocompromised individuals. As both acute and chronic hepatitis would be showing a dense T lymphocytic infiltration, it has to be differentiated from autoimmune hepatitis, drug-induced liver injury, and Wilson's disease. In chronic viral hepatitis, there will be extensive fibrosis, and it can be demonstrated only with the biopsy of the liver along with a special histochemical stain of Mason trichrome to determine the therapeutic course of action. The patients with hepatitis B virus or hepatitis C virus are at increased risk for development of hepatocellular carcinoma in about 2 to 3% of cases, especially in the setting of cirrhosis, because the viral particles nucleic acid is integrated with the host DNA. So these are the salient features about viral hepatitis we have to remember. Thank you.